Now we're going to be talking about nasal polyps. And nasal polyps are benign grape-like clusters of mucous membrane and connective tissue. They often occur bilaterally and are caused by irritation to the mucosal, the nasal mucosa or the sinuses. Allergies, infection, chronic sinusitis can cause them. Large polyps may obstruct the airway. So we'll have signs and symptoms of obstructed nasal breathing, increased nasal discharge, and a change in voice quality. Benign nasal polyps are managed with nasally inhaled steroids, followed by surgical removal or a polypectomy, with standard or laser surgery performed. Make sure that you observe the patient for any bleeding after surgery. And the nostrils are usually packed with gauze for about 24 hours after surgery. And the really sad part is that these nasal polyps can recur after treatment. I've only seen one case of this, and it was really, really bad. You just take a nasal speculum at the with a light on the end that you use to look in the ears. If you look up in there, they exactly look like grape-like clusters, and but they're very, very annoying for patients. And remember that when you have any kind of obstruction, you have nasal breathing, you are more likely to become dehydrated. So make sure that they know that they need to drink a lot. So we'll go on to cancer of the nose and the sinuses. This can either be benign or malignant. Malignant tumors can occur at any age, but the peak incidence is 40 to 45 years of age in men and 60 to 65 years of age in women. And Asian Americans have a higher incidence of that nasopharyngeal type cancers. This type of cancer, the risk factors for this are people with chronic exposure to wood, dust from textiles, leather dust, flour, nickel, and chromium dust, mustard gas, and radium. And cigarette smoking, along with these type of exposures, will increase the risk. So the onset is usually slow, and it manifests usually resembling a sinusitis. Thus, the patient can have an advanced disease at the diagnosis because of the slow onset. So our signs and symptoms are nasal or of the nasal or sinus cancer. Those signs and symptoms would be persistent nasal obstruction, drainage, bloody discharge, and pain that persists after treatment of sinusitis. You may have lymph node enlargement, which occurs on the side with the tumor mass, and the tumor location is identified usually with an X-ray, CT, or an MRI. A biopsy is performed, of course, as you know. Got to do a biopsy to confirm the diagnosis. So we can have surgical removal of all or part of the tumor is usually the main treatment for nasopharyngeal cancers. It's usually combined with radiation therapy. So we want to break, especially if it's a very bulky tumor, we want to make sure that we get it smaller and then maybe can do some surgery on it. Usually our general post-op care is maintaining a patent airway, monitoring for hemorrhage, providing wound care, assessing nutritional status. We'll need to perform trach care if they do have a trach, perform careful mouth and sinus cavity care with saline irrigations, usually a water pick or a sonicare or a syringe, assess the patient for pain, infection. Good nutrition is important after surgery, and that being said, we're looking at our protein foods, our vitamin C foods for after surgery. Chemotherapy may also be used in conjunction as an adjuvant with surgery and radiation for some of those tumors. Those most commonly used agents for cancer of the nose and sinuses are carboplatin, cisplatin, 5-FU, docetaxel, and paclitaxel. Again, we when we have this type of diagnosis, cancer of the nose and the sinuses, we're looking at nutrition and we're looking at airway throughout the respiratory system. Okay, then now we're going to go on to facial traumas, and these the facial trauma is usually described by the specific bones that has been affected, such as the mandibular, maxillary, orbital, or nasal fractures, and the side of the face that's involved. This is it's called a Lefort 1, 2, and 3, and it gives you the different bones that are involved, the complex fractures that are involved, and Lefort is 3 is that craniofacial dysfunction that you see with orbital and zygomatic type fractures. You do not have to memorize that, but if you ever see it, and I doubt that you'll see it on boards or anything, but if you work in the ER, you may have a patient that comes in with this, with facial trauma, and this is just kind of a grading of that facial trauma to describe what bones have been traumatized. The priority action is to take for a patient with facial trauma, of course, is airway assessment. Very, very important. Manifestations, it gives you some signs and symptoms in your book of airway obstruction, including the stridor, shortness of breath, dyspnea, anxiety, restlessness, hypoxia, and elevated blood levels of CO2. So they'll probably definitely do an ABG. We'll have decreased oxygen saturation, cyanosis, and loss of consciousness. After establishing that airway, assess the site for any trauma, for bleeding, any possible fractures, check for soft tissue edema, facial asymmetry, pain or leakage of the cerebrospinal fluid through the ears of the nose, because that could indicate a temporal bone or a basilar skull fracture. Assess vision, eye movement. Check behind the ears for any kind of extensive bruising, especially on the mastoid area. That's known as the battle sign. Just remember that the priority action is to establish and maintain an airway. Very, very important. When you have facial trauma, anticipate the need for emergency intubation, such as a trach. They may have to put a temporary airway in by making a small opening in the throat between the thyroid cartilage and the cricoid cartilage. And upon arrival, focus on the airway, control the hemorrhage, and assess for that any extent of the injury. And if shock is present, make sure that we give fluid, resuscitation, and identification of bleeding sites, are started immediately. Time is crucial in these types of patients. We need to stabilize the fracture. We may have to, especially if it's a segment of the jaw, that we need to, maybe they'll do what they call a fixed occlusion, which is wiring the jaws together in the mouth, and the patient may remain in that fixed position for like 6 to 10 weeks. There's also ORIF for more extensive jaw fractures, or they may even have to do a bone substitute with facial surgery. After surgery, depending on what type of surgery they've had, they will teach the patient about it's important that we teach the patient about oral care with an irrigating device, such as maybe a water pick or Sonicare. If the patient has intermaxillary fixation, teach the patient self-management with wires, including a dental liquid diet. If the patient vomits, make sure that you watch for aspiration because of the patient's inability to open the jaws, to allow for ejection of the emesis, especially if they can't open their jaw. Teach him or her how to cut the wires if the emesis occurs, and instruct the patient to keep those wires with him or her at all times in case this emergency does occur. And if the wires are cut, instruct him or her to return to the surgeon, for rewiring as soon as possible to reinstate fixation. Nutrition is super, super important, and it's difficult with these patients with fractures because of the oral fixation, the pain, and the surgery itself. So a lot of times we'll have to collaborate with a dietitian for patient teaching and any support that's needed.